Welcome, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I am the Senior Manager of Scientific and Clinical Programs here at Osteoporosis Canada. I will be your moderator for today's webinar, an overview of the new guideline on the management of osteoporosis for healthcare providers. But before we begin, Osteoporosis Canada acknowledges the land that our offices in Toronto are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. At Osteoporosis Canada, we educate Canadians about bone health, including healthcare professionals and their clients. We are the only national organization serving people who have or are at risk for osteoporosis. We are really excited about today's presentation, which will provide information about Osteoporosis Canada's new guideline on the management of osteoporosis for Canadian healthcare providers, with information focusing on nutrition, exercise, fracture risk assessment, treatment, and much more. It is not intended as individualized health advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we'll try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. It is now my pleasure to introduce our speaker, Dr. Suzanne Morin. Suzanne graduated from the Faculty of Medicine at Laval University, did her internal medicine specialty training, and obtained a master's degree in epidemiology and biostats from McGill University, where she's now an associate professor in the Department of Medicine, the director of the Division of General Internal Medicine, and scientist at the Center for Outcomes Research and Evaluation of the Research Institute of McGill University Health Centre. She is our past chair of Osteoporosis Canada's Scientific Advisory Council and a member of the CIHR Institute of Musculoskeletal Health and Arthritis Advisory Committee. Dr. Morin's research program focuses on the evaluation of outcomes of osteoporosis and its treatment and implementation of initiatives to reduce fracture risk with an interest in digital health applications. So without further ado, please join me in welcoming Dr. Morin.
Thank you very much, and I'm looking forward to this presentation. I'm going to share my screen now. Here we go. I trust everybody can see. And we're going to discuss today the most recently obviously published Clinical Practice Guideline. And of course, before I begin, I want to thank everybody who participated in this massive work, including wonderful support from Kerry, Grady, and the multiple people who were part of the working groups, as I will show you throughout this presentation. My disclosures are mostly with me being a member of the advisory board of IMHA for CIHR. So the learning objectives are here. We're going to discuss the importance of fracture prevention in Canadians. We're going to describe the process that supported the development of the guideline, and we're going to discuss the guideline and engage on how we can implement the guideline recommendations into our practice and hopefully into our various communities. I want to also highlight the fact that this work is actually a guideline. It's meant to guide people, and therefore there's always the importance of clinical judgment, of individual presentations of diseases and other comorbidities of patients who come into play all the time. And so it's really important to use the guideline as a way to think through the kind of the evaluation and the treatment process, but of course, in discussion with patients and their family members, and always ensuring that it aligns well with the patient comorbidities as well as their wishes. So briefly, osteoporosis, as you know, is a disorder of bone strength, not only a disorder of bone density, as we often rely on bone density in the clinical realm, but bone strength is more than just bone density. It's also about bone quality and bone geometry. All of these factors are also influenced by biomechanical, biological, and genetic factors that come into play. And when we look at bone density, this is the test or the surrogate test that tells us about bone strength and how we can evaluate the risk for fractures. However, we have to always keep in mind that bone quality is important, and many comorbidities will affect bone quality before they affect bone density. One of an example is if you start someone on large doses of glucocorticoids, for example, then the bone density will not go down rapidly, but the bone quality will be affected very rapidly. And then the person is at higher risk for fractures, but the bone density really hasn't changed. It's the bone quality that has deteriorated. And here you see in pictures under demonstrating obvious pictures of people who have skeletal fragility, where you could see that the microarchitecture of the bone is diminished and altered, leading obviously to a loss in bone strength. Osteoporosis is often considered a disease of older men, but we have to pay attention to men as well, as 1 in 3 fractures occur in men. Also, men have greater fracture-related morbidity and mortality and suffer higher rates of subsequent fractures following a fracture. Therefore, when men show up with a fracture, they often have more advanced disease than women do and have to be taken seriously, although most of the patients who have fractures still are women. And you could see this in the graph on the right side of your screen, where we could see females versus males. And this is data from the Public Health Agency of Canada over age groups, where you could see that the fractures do increase. The prevalence of fracture does increase over age, but you could see that in men, it starts to really go up after the age of 70, whereas in women, it starts to go up after the age of 55, but mostly with distal forearm fractures. But as both groups age, fractures of the spine, fractures of the humerus, pelvic, and spine also increase significantly. Here we see a graph that shows the usage of medication or the diagnosis of osteoporosis or having received a bone density in the year following the fracture. So this is again data from the Public Health Agency. I want you to concentrate mostly on the solid red and blue lines, where we see the percentage of patients who receive treatment in the year following a fracture. And you could see in red the women and in blue men. And you can see that only 15% of men will receive treatment, and only approximately 22% of women will receive treatment that will reduce the risk of future fractures in this population who's already sustained a fracture. So a lot of education, a lot of work to do to identify people who've already sustained a fracture and would benefit, not all, but most of them would benefit from treatment. So let's go back to the guideline. So the guideline were published in 2023 in October. The target audience are primary healthcare professionals, obviously in Canada, and we direct these guidelines to postmenopausal women and men who are 50 years and older. So we are not here to discuss in this guideline premenopausal women or people who are younger than the age of 50 or people who have multiple severe secondary causes of osteoporosis. we're looking here at the target population of generally healthy postmenopausal women and men over the age of 50. So we set on this work in 2019, and we developed the structure to ensure that we would have the appropriate structure to create guidelines that would be both valid and also recognized for their excellence. So we created a steering committee, and we thought that the GRADE approach, which I'm going to describe a bit better, is a method that allows to take into consideration the strength of the evidence, as well as other important things, such as the importance of patient partners, of primary care partners, in terms of their both preferences as well as their experience in daily practice. We also took into consideration the impact of the recommendation on the societal cost, as well as whether it would be feasible to implement. On the steering committee, we had primary care providers, patient partners, clinicians, and researchers. We then developed a conflict of interest committee to ensure that we abided by the CMAJ guidelines in terms of conflict of interest reporting. And then we had working groups, 4 of them specifically, and we had the fracture risk assessment working group, the pharmacotherapy working group, nutrition and exercise. And all of these working groups met separately and looked at various important questions that we felt and that the patient partners felt and the family physicians felt should be incorporated into the new guidelines. So we very much used an approach of asking people, clinicians and patient partners, what they wanted to see in the new guideline, what was important to them, and how should we address these questions. And in fact, the patient engagement paper was published to reflect that. We are using the GRADE framework, which I just described a little bit, but using this framework actually also comes with a very specific vocabulary when you develop your recommendations. And so when you look through the document, you will note that we either recommend or suggest, or we recommend against or suggest against. And these 2 words, although may seem synonymous, they're not. And recommend is usually used when the consequences of following the recommendation clearly outweigh the undesirable consequences or the potential harms. And it is interpreted by both clinician and patients as that most people would agree to receive this recommended course of action. When we use suggest, usually there's a bit more uncertainty, and the uncertainty is not around only the evidence. It could be around the feasibility of implementing this particular recommendation. It could be about the cost of implementing this particular recommendation. So the recommendation is a stronger verb, which allows for people to interpret this as being a obviously a stronger recommendation than the conditional recommendation of we suggest. So overall, we developed 25 recommendations and 10 good practice statements. Good practice statements are statements that are thought to not require extensive searches, literature searches, or knowledge synthesis, either because they've been in the clinical realm for many years, or because it is felt that it would not be worth the time to look up all of the references, because this is something most people would agree with. So the big changes from the 2010 guidelines is that we use the GRADE framework, and we've expanded our recommendations on exercise and nutrients. And I'm only going to touch here, however, on calcium and vitamin D, but you can see on the document that we've expanded on that. We've also provided clearer guidance on treatment initiation, duration of therapy, and monitoring. And we provide some guidance, not a lot, but some on the use of anabolic therapy. And so you have to understand that also there are a limited number of questions that we can or we could address as a group. And there are still quite a lot of questions that remain, some of which we've highlighted in the document in the last sections. And so the goal is that we will continue to work particularly towards having guidance for specific populations, and also trying to understand better, as you'll see, the screening process for younger population. So when we look at fracture risk assessment, so fracture risk assessment is how we look at the person in front of us, so the patient, and see whether there are any evidence of risk factors for skeletal fragility. Now, we may not know their initial bone density, we may not know if any of these risk factors are present. So of course, we do have to question patients in that nature. But in general, we recommend that we should address them looking at whether they've had previous fractures. And here we concentrate on fractures that seem to be out of proportion with the trauma that was sustained. We know that fractures, even if traumatic, can predict non-traumatic fracture. But obviously, if someone has been in a large car accident, the fractures may not be as, surprising as they would be if somebody falls from their own height. So we look at lowish trauma fractures, and we exclude the fractures of the hands, the feet, and the head and C-spine, because they're usually not considered osteoporotic in nature. We look at other risk factors, whether a parent fractured the hip, secondary causes of osteoporosis, current smoking, alcohol, and the use of glucocorticoids. Now, this is, as you know, for those who know the FRAX tool, these are some of the risk factors that are incorporated in the FRAX tool. So you could use a FRAX without BMD if you wish, or you could just look at these risk factors. And of course, we know that low body mass index is also associated with an increased risk for fracture. So these are the main ones. And we look, oh, sorry, I forgot about the falls. As you know, falls is not yet incorporated in FRAX, but it will be in the next version of FRAX 2, that should come in the clinical world, probably within the next 2 years. In the supplementary tables in the appendix, you will find a table that will list all the secondary causes of osteoporosis. Of course, not everybody can remember all this all the time, but this is a good guide. If you're concerned one of your patients may have a secondary cause, you can find the list here. Now, if you do find someone with a secondary cause, we also recommend that you try to correct the underlying disorder if possible. And if required, you may seek, an expert in the area, a specialist, a gastroenterologist or whatever, to either make the diagnosis or to help manage the patient. Usually, if you can correct the underlying cause, then often the bone loss will improve, but it's not always possible, obviously. So when do we do a bone mineral density test in people who are the target audience? So the bone density test is used here not so much to make a diagnosis of osteoporosis, but really to help out in the fracture risk prediction. And it is really important. As you will know, there's been a change in the treatment thresholds, but we want to make sure that we also calculate the fracture risk. We recommend that, and as I'll say, is the fracture risk is calculated with the BMD. So we do ask that people who are over the age of 50 to the age of 64, who either have a previous fracture or 2 or more clinical risk factors, as we went through on the previous slide, have a bone mineral density to help refine the fracture risk assessment. or if you are over the age of 65 with one clinical risk factor, or if you are over the age of 70. So this has changed. We used to say 65 was the age where people should undergo at least one bone mineral density. Here, it is, we've pushed it all to an older age group and have tried to provide further guidance on who should have a bone density earlier in the presence of the risk factors. And these risk factors are listed for you in that figure 1 in the guideline. You will note also that if there are signs of possible vertebral fracture, then it becomes important to image the spine to try to demonstrate whether there is a vertebral fracture. The presence of a vertebral fracture will change potentially treatment and also may change the type of medication you give or how long you treat for. So it is important to look for these vertebral imaging. If you have clinical signs of undiagnosed vertebral fracture on exam, as is listed in figure 1, or if you are older than age 65 with a T-score that is within the osteoporosis realm, or if you have a risk factor, a 10-year fracture risk of major osteoporotic fracture between 15 and 20%. So these are the recommendation again, and you can see here that we suggest as opposed to recommend. And the reason we suggest is that the evidence, particularly for males, is lower, as is noted down below. Which tool should we use? There are many. In fact, in Canada, we use 2. We use the Canadian specific FRAX tool or CAROC, which is a semi-quantitative FRAX. Now, CAROC was designed with the previous 2010 guideline when we had these kind of low, moderate, and high risk category where the fracture probability scores were, below 10, between 10 and 20, and above 20. As you will note, as we go through later, these various categories have changed, and so it may make it a little harder to use CAROC. And we also recommend that FRAX is the preferred tool because it does provide a more sensitive and valid fracture risk assessment, and also because within the next few years, FRAX 2 will be available and will incorporate other variables such as falls, type 2 diabetes, maybe also the number of fractures. So there's a lot more that will come with FRAX 2, and we will not be able to update the CAROC tool. And so we understand that this may cause a lot of more work for people, but we hope that eventually people will be able to transit to the FRAX. However, if you prefer CAROC, it is still fine to use CAROC, and it is good to use a fracture risk assessment tool. So that's why we recommend that you use at least either one of them. Now, so we have gone down now the algorithm. We've obtained the BMD, and we've calculated the 10-year fracture risk with BMD using FRAX or CAROC. And so both here are important because the BMD on its own may help you, but it is also important to calculate the fracture risk because in some people who do not have low BMD, their skeletal fragility risk will be better assessed with the clinical factors that are involved in FRAX or CAROC. For example, males tend to have less often a very low bone density, but if they've sustained multiple fractures or if they've taken or taking large doses of steroids, this will be incorporated in the FRAX tool and will increase their risk, whereas the bone density by itself would not be a sufficient way to approach their fracture risk assessment. So we do recommend you do both. Now, once you have the FRAX calculated, you will have then a 10-year major osteoporotic fracture risk of 20% or more, or less, as you could see in these various boxes. Now, a change is that we recommend that people who have a T-score below or equal to -2.5 and are older than age 70, this actually meets a treatment threshold for the recommend pharmacotherapy box, where the largest benefits will be seen. These data are more robust in women, and essentially this box here is where we are going to treat people because they have shown you that they are at high risk of skeletal fragility. Many of these people have sustained already fractures. Now, if somebody has had a previous hip or spine fracture or more than 2 fragility fractures, people could say, well, we don't really need a bone density. And it is true, you do not need a bone density to initiate therapy, but you may wish to have a bone density as a baseline because you will probably wish to monitor the impact of your medication on a bone density, which is currently the major tool we have to follow the results of your treatment. Now, these stars that you see throughout, again, remind you that you should consider vertebral fracture imaging in these people to ensure that you would take that information into consideration, because it may impact the choice of medication and the duration of treatment. Now, for those people who do not meet the thresholds for initiating therapy or choose not to initiate therapy after conversation, then we recommend BMD be repeated so that you can continue to assess their risk. And so if the 10-year fracture risk was below 10, then we could recommend that people have another bone density in 10 years from now. If the risk was between 10 and 15, 5 years, and if more than 15, 3 years. Obviously, this is a guidance. And if the patient develops new risk factors or obviously has a fracture, this will change, and you should then follow the kind of the initial algorithm. So here I show the entire algorithm in figure 1, and this will be available as a quick fact sheet where you will have all of this in one place that you could keep either on your desk or in your office or on your desktop. But essentially you have here all the entire kind of treatment algorithm, or sorry, the kind of the evaluation and treatment algorithm. Missing on this are, of course, the recommendations for exercise and nutrition that we're going to come back to. But you have your risk factors to consider. You have, excuse me, you have the when to proceed with a bone density, how to calculate the fracture risk, and then divide people into those in whom we recommend therapy, those in whom we suggest therapy, and those in whom we do not recommend. So you could see here, do not recommend or recommend against, and recommend therapy, and then how you follow that up. All right, so let's go quickly to nutrition and exercise recommendations, excuse me. So you see this box comes right at the top before the identification of fracture risk, and we recommend balance and muscle strengthening exercises more than twice weekly. We suggest that people eat food rich in calcium and protein, and we suggest a minimum of vitamin D of 400 units daily as per Health Canada's recommendation. I'm not going to spend a lot of time on calcium, but rather on vitamin D. Calcium, is important to consider taking it mostly from your diet. And I'll show that a bit later. So vitamin D, we don't recommend measuring the levels unless people are at high risk of insufficiency, which I'll show you. What I want to highlight on this slide is that the adequate level is actually above 50 nanomoles per liter, and there is very little benefit in having a very high level of 25-hydroxyvitamin D. And if you have some level that's below 30, this should be, improved by supplementing with higher doses of vitamin D, maybe for a while. Health Canada recommends that people up to the age of 70 take 600 units of vitamin D per day, above 70, 800. If you were to take this 600, you would have approximately 50 nanomoles per liter of a 25 hydroxy D level. Because it is difficult to obtain vitamin D in the diet, Health Canada actually recommends that all adults over the age of 50 take 400 units. So this does not eliminate the recommendation of 600 and 800, but it is supplemented because of the fact that it is difficult to obtain in the diet. I'm just going to concentrate on the right-hand side of the screen, where we looked at the Canadian longitudinal study on aging, which included here 22,000 men and women. And we looked at people who were taking vitamin D supplements. So you could see 40% up to 50% by race or ethnicity categories were taking supplemental vitamin D, quite a large proportion. And this includes as well multivitamins. And we measured their vitamin D level, the 25 hydroxy. And you can see that most of these people, of course, even if not all were on supplemental vitamin D, the average level was well above 50. So it is reassuring to know that in Canada, most people are actually sufficient in vitamin D. Of course, there are people who are not. I'm going to skip this for time. And we need to look at these people specifically. And I here put this on the right-hand side of the screen. All these conditions put people at risk for vitamin D deficiency and should be sought out in your patients if you want to ensure that their vitamin D level is correct. So that's the recommendation that we suggest following Health Canada's recommendation on vitamin D for bone health in order to ensure a level that's 50 nanomoles or higher. Now, the Canadian, in terms of calcium, as I said, we recommend approximately 1,000 milligrams per day. It is advisable to take this calcium in the diet because calcium is associated with a lot of nutrients in food, such as protein often, as well as, phosphorus and magnesium and other important minerals. We encourage you to go look at the Osteoporosis Canada website, where there is a nutrient calculator. You can show this to your patients, and they can actually calculate the amount of calcium, vitamin D, as well as protein and other nutrients in their diet. And this will help them, try to make sure that they are close to our recommendations. In terms of exercise, we recommend progressive resistance training, which has to do with lifting little weights or using elastic bands. And we recommend people do this at least twice per week, as well as balance and functional training exercises at least twice per week. And this is to reduce, falls and falls-related fractures. This includes yoga, exercises where you challenge your balance, such as throwing a ball with a friend or a partner, and doing these exercises to ensure that throughout the years your balance remains as good as possible. Impact exercise has been shown to improve BMD and physical performance, and some exercises as well to improve hyperkyphosis, have been described. But what we really suggest people to concentrate on are the resistance training as well as balance and functional training. And these are extremely important. It is not that people should exclude aerobic exercises if they do it and enjoy it. That is fine. But what will reduce in better bone strength and less falls and fractures are these two types of exercises on the left. I point you here as well to some very well done tools that you can find on the Osteoporosis Canada website in order to help your patients move forward with these types of exercises. If we move down to pharmacological interventions, and most of you are very aware of these molecules, they've been around forever, and not much has changed since the last guideline. And we recommend pharmacological interventions in the two groups on the right-hand side. Medications, as you know, are usually defined as being anti-resorptive or anabolic in nature. The anti-resorptives tend to slow down bone remodeling, allow for secondary mineralization, stabilization of the microarchitecture, and reduce fractures in that fashion. Anabolic agents increase osteoblastic function with the deposition of new matrix, which then gets mineralized and is, of course, provides increased and stronger structure, particularly at the microarchitecture level. Both agents, of course, both types of agents actually reduce fractures. Now, in Canada and elsewhere around the world, bisphosphonates really are first-line agent, and this is what we also recommend. And these medications are first-line agents because they are well tolerated, because they are fairly cheap, and they have been shown to be generally safe over time. Now that we know to use them a lot better. The rank ligand inhibitor, denosumab, is the most potent anti-resorptive agent we have, and we do recommend it in the second line. I'll go through this to reduce fractures in people who have contraindications who cannot take bisphosphonates. Anabolic agents, we have two on the market here in Canada, teriparatide and romosozumab. These agents are used, as I mentioned, to increase bone matrix and have to be used for a short period of time, as opposed to the other medications above. And following their use, we have to then switch on to an anti-resorptive, so not to lose the benefits we have gained from these medications. This is figure 2, again, a figure that will be important for you to keep close by. And I also want to point out that there is a table on all the medications, side effects, posology, and how to use them and what to be concerned about. Again, in the guideline, it's a very nice table. So if we have recommended or suggest that people initiate therapy, the first step is to ensure that they actually haven't sustained a recent severe vertebral fracture above 40% height loss of the vertebra, or more than 2 fractures and with a low T-score. If that's the case, you should immediately consider in your patient whether they would be a candidate for anabolic therapy. The reason why that is in 2 key studies, it has been shown that people who were treated with an anabolic agent had a lower risk of fractures compared to people who were treated with a bisphosphonate. And so this allows us to recommend that there be consideration for anabolic therapy in these patients. Now, as I've mentioned previously, should your patients go on anabolic therapy, it is important to follow this up with anti-resorptive therapy for a short or longer period of time, depending on your patient's status. If we go with bisphosphonates, we usually recommend the oral route if possible, if not the IV route. The IV route is given at every 12 to 18 months, but of course requires an infusion. And so this depends, of course, with your patient and whether this is something that they may wish to do or be obviously reimbursed by their provincial drug plan. Should there be contraindication or impossibility to take oral or IV bisphosphonates, then we recommend denosumab. And as I'll show you, denosumab is given, of course, in a subcutaneous injection every 6 months, but should be continued on for long term because of the serious adverse events that can come if you stop the medication. Initial treatment should be for 3 to 6 years with a bisphosphonate, and then a reassessment of your patient should be done looking at whether bone density has stabilized, whether fractures have stopped occurring, and whether there are no ongoing important risk factors that can actually continue to affect bone strength. If this is not the case, then you can look at continuing therapy, or if there is inadequate response, then you can extend or switch medication. And here again, the guidance we have is less strong and requires us all to kind of think it through and speak with the patient and see what their goals are. So duration of therapy, we suggest that medication, bisphosphonates, be followed with an interruption or a drug holiday in people who have stabilized, as I mentioned before. And the reason for this is because if you use bisphosphonates uninterrupted for many years, there is a risk of atypical femur fracture, and this risk increases with the duration of treatment, being very low when the treatment is used for less than 3 years to much higher when the treatment is used for up to 10 to 11 years. And so we recommend that people stop treatment. The effect of the medication will continue, albeit at a less potent rate, but the medication continues to have an effect for 1 to 2 years, depending on the bisphosphonate that was used. And we know that if we stop the bisphosphonate, the risk of atypical femur fractures does go down. Usually within 2 years, it's gone down to base level, which allows us then to again use a bisphosphonate in treatment, because we know that the effect of the cumulative bisphosphonate drug on the bone has been cleared from the skeleton. Osteonecrosis of the jaw is actually less frequent in people with osteoporosis, of taking bisphosphonates for osteoporosis, but it does exist. And again, similarly to atypical femur fracture, increases with duration of therapy. Denosumab does have an association as well with atypical femur fracture and ONJ. People often don't realize this, and it's not only in people who've taken bisphosphonates before, it is often in people who have not taken a bisphosphonate before. So this is something that we should also mention to patient. And however, the risk of atypical femur fractures and ONJ is actually lower in denosumab, and that's probably because of the mechanism of action, where denosumab allows for bone remodeling to go down when it is first injected, but then bone remodeling comes back up to almost normal, but not in all, but in most people, come back up to allow for some bone remodeling process to occur prior to next injection. Now, because denosumab is not retained in the skeleton, we do not recommend a drug holiday, because if you stop it, there is a rapid loss of bone density. Within 1 year, people will lose the gain they will have made. And that rapid loss in bone density is because of a very high increase in bone remodeling turnover, which is associated with bone loss. Then this bone loss is particularly important in the spine, and you have heard, I'm sure, of these symptomatic non-traumatic vertebral fractures that can occur in patients who stop denosumab. If denosumab, the patient wishes to stop, then if there's been less than 4 doses, we recommend that people transition to an oral bisphosphonate for 6 to 12 months in order to prevent this rebound. If it's been more than 5 doses, then it is recommended that the patient uses IV bisphosphonate, but we recommend seeking advice from an expert in this field. In terms of monitoring, we recommend, of course, that patients are followed and that we inquire about new risk factors and, of course, new falls and fractures, as well as adherence to therapy and the monitoring of adverse event. We, of course, remember to counsel regarding ONJ and AFF, should there be thigh pain or thigh or groin fatigue. We do not recommend that people use bone turnover markers to monitor either the effect of therapy because there's a few still problems with these tests, and they also vary from lab to lab. So in terms of the gaps in knowledge that we feel remain is, as I've said before, we have answered some questions. Some of the questions we were able to provide more robust guidance. Some of the questions we were not able to provide robust guidance, but still able to provide some guidance. And still yet there are some questions that we were not able to answer. And the evidence regarding management in men and in younger people requires, to be increased. There's not a lot of randomized controlled trials that guide us in how, what to do with these two populations. We also need more evidence on sequence of treatments. Can we use, anabolic agents again once we've used them before? Right now, it's not really recommended, but sometimes people do it off-label. So we need more information about that. And we need probably more develop fracture risk assessment tools that include more variables, particularly falls, because we all know that falls is an important risk factor for future fractures. So here I point you to some important websites where you can find tools, some of the tools I've mentioned throughout. So obviously the publication is at CMAJ. It's also on the Osteoporosis Canada website. There's the Canadian Osteoporosis Patient Network, which actively participated in the creation of these guidelines, where we had patient partners, as I've mentioned, on every single working group and the steering committee. And all these patient partners actually are authors on the guideline. Calcium calculator. And there's a tool here to also on the website that will help you in discussion regarding treatment initiation, particularly with bisphosphonates. There will be coming also a mobile app where the guideline will be in the mobile app, helping you kind of select or identify properly your patient's fracture risk as well as the best treatment options. So I think that's it. So I'm going to stop sharing here, and I'm happy to take some questions. I believe Kerry will guide us in this.
That's great, Suzanne. Thank you so much. So much information to think about. So as you said, we'll turn to the question and answer period. We do have some questions coming in. So let's start with this one. What are the differences between this guideline and the 2010 guideline?
Right. So I think I've mentioned it, but I think, again, what is really important is the age at which we recommend that everyone has a bone density. So we've pushed that back to 70. We also, as I said, provide kind of a suggestion to use FRAX over CAROC. We recommend strongly that fracture risk be assessed, as well as using the bone density to look at how you're going to treat your patients in terms of these three various groups. And we recommend, strong recommendation for treatment in those at high risk who've had multiple fractures. We recommend against treatment, pharmacological therapy, in those whose risk is found to be low. And those in the middle, really, we say people should have a lengthy discussion with patients, shared medical decision to ensure people understand the benefits and the harms, which would be slightly higher in that group. I think that's pretty much it.
Okay, that sounds great. Here's a few more. So is it possible to get all the calcium you need from your diet?
Yes, so it is possible, but it usually implies that people will agree to take dairy, or they take a lot of these plant-based beverages. And because usually a portion of almond milk, a portion of cow milk usually contains about 300 milligrams of calcium. A yogurt, kind of regular yogurt, a piece of hard cheese, these are all about 300 milligrams of calcium. And there's a bit of smattering of calcium throughout the diet. So you can, if you take at least 3 portions plus a varied diet, you can get your calcium. And this is what I encourage people to do. If people cannot do this for various reasons, then we recommend a calcium supplement, but usually no more than 500 milligrams of calcium, because it is, as I said, not replete with other nutrients as you find in the diet. And calcium supplements will cause little peaks in calcium levels, which the calcium supplement doesn't do. And so I think if you can recommend, diet first, this is what we suggest people do.
Okay. We'll stay on the nutrition track here. Just one more nutrition question. What are the benefits or risks of taking really high levels of vitamin D?
Yeah, so there's no benefits in having a vitamin D at 25 hydroxy D level of above 50. If you get to be above 125, we think there's harms there, potential. And the harms include having more calcium leak out in the urine, so hypercalciuria, which could essentially lead to calcium stones. It's been shown in people who take very, very high levels of vitamin D that actually there might be some detrimental effect on bone strength. And that's been shown through a study in Calgary, where some groups of people took 10,000 units of vitamin D3 per day. These people did less well in terms of bone strength than people who took the 1,000 units per day. So there is a risk in taking too much vitamin D.
Okay. We have time for a few more questions. Here's one. Do medications become less effective over long-term use? I think you answered that in your presentation, but.
No, so medications, bisphosphonates. So obviously bisphosphonates and denosumab, these are the 2 types of medication we usually use long-term. And all these medications continue to work. The problem is the longer you are on them, particularly bisphosphonates, the kind of the accumulation of the medication and its effect on the bone material can lead to adverse events. So yes, the bone density will continue to improve. Yes, the bone, kind of the secondary hypermineralization will continue to improve. But at one point in certain people, not everyone, this can have a detrimental effect. So that's why with bisphosphonates, we think it's better to kind of take time off. With denosumab, we still see the bone density going up, and we still see an effect on the bone markers and all this. With denosumab, the danger is when you stop it, all this goes away. So this is important that we continue to, if there's an interest in stopping medications or continuing, you have to speak with your physicians to discuss this, obviously. And the discussion with the patient is extremely important. And sometimes people will take their advice from pharmacists, from other healthcare professionals. So it's really important that we all have the same kind of story to say.
Okay, thanks, Suzanne. The following will be our last question. Somebody has asked, do we need to calculate fracture risk if it's reported in the BMD report?
Yes, you do. And the reason I say this is because it is not always clear how the radiology clinic actually calculated the risk. And sometimes people use only the age, the sex, and the BMD result. And so maybe you have more information about previous fracture, familial, parental history of hip fracture, other things like this that the clinic or the technician may not have. So it depends very much which clinic you use or send your patient to. So if you're very confident that they obtain all the information, for example, that is within the FRAX or the CAROC tool, then fine, you can certainly go and not have to recalculate it. But if you're not sure, then I suggest you do. It doesn't take very long to get these risk factors ascertained, but it does take 5 minutes, 10 minutes. And yes, it takes time. And I know, family physicians don't have a lot of time. But some people ask their patients to calculate or bring in a sheet where they've ticked off these things. There's various ways of doing it. But I have found often that the risk is not calculated properly, not because they're not trying to, it's just because they don't have all the same information we have.
Okay. Well, on that note, I want to thank Dr. Morin for an informative presentation on the new guideline. That was great. I want to let people know that if they need more information on osteoporosis, to please visit our website at osteoporosis.ca. And on our website, you're going to find many tools, including the calcium calculator, podcasts, quizzes, and a repository of our past webinars. So at this point, I just want to say thank you to everyone for joining us today and wishing you a great day, and hope to see you again soon. Thank you.
Thank you.